Hello, everyone. Good morning, good afternoon, and good evening. We have a truly global audience today. Welcome to today's session, and thank you for taking the time from your busy agendas to be with us today. My name is Filomena Gonçalves. I'm a Senior International Marketing Manager at Natus Medical, and I'm going to be your host for today. With me today, I also have Dr. Sanjeev Nandekar and Mr. Simone Poggi. We will assist on the Q&A session. Before we get started, I would like to go over a few housekeeping items so you know how to participate in today's event. Now that you have joined, you will notice that you're on mute. This will allow us to manage background noise during the presentation and ensure you have a good experience with us today. We will allow time for questions at the end of this presentation. Please type in your questions in the question box on your screen. You can open the question box by clicking the white arrow in the control box. You may type in your questions at any time during the presentation. We will collect these and address them during the Q&A session and at the end of today's presentation. This meeting is being recorded and it will be available for viewing at a later date at the Neurotraining Academy website. Today's webinar is about Jitter recordings with concentric needle electrode, and it's my absolute pleasure to present you with our speaker for today, Professor Erik Stålberg. Professor Stålberg is a professor emeritus at the Uppsala University, where he has spent his life to learning, teaching, research, and patient care. He is internationally recognized for his contributions to electrodiagnostic medicine. He pioneered the technique of single fiber EMG and also other methods on quantitative analysis. He has promoted quantitative analysis and telemedicine. He has trained many luminaries in this field. He has published over 440 articles, written chapters in many textbooks, and co-authored the book Single Fiber EMG. He has lectured in many countries and conferences where he has been showered with recognition and awards. Among them, American Association of Neuromuscular and Electrodiagnostic Medicine gave him the Distinguished Researcher Award and a Lifetime Achievement Award. Professor Stålberg, it's a pleasure to have you with us today. The floor is yours.
Thank you very much, Filomena, for a very nice introduction. I'm happy to be here with you, and it's a fantastic crowd that you have collected. As all of you may notice, we have the title of this webinar as Jitter recordings with concentric needle electrode. We did not call it single fiber EMG with a concentric needle electrode, since first of all, it may not be single fibers all the time. And the other thing is that with the concentric needle electrode, we do not measure all the parameters that can be measured with the original single fiber electrode, such as fiber density and a few other things. So we keep this to the thing that is most practical right now, the use of concentric needle for the reason that you know about. We can do very well with small concentric needle electrodes, and that's what we are going to discuss during the coming 20-30 minutes, and then after that, I will be ready to answer your questions. So I'm going to start my presentation now. As a consequence of restrictions on the use of reusable material in many countries, the concentric needle electrode, CNE, has been shown to be a reasonable replacement for SFEMG electrodes to measure jitter. With the CNE electrode, we cannot measure fiber density. New standards are necessary, which will be discussed in this video. First, a few words about single fiber in general. This is the uptake area of the single fiber electrode, 200 micron in radius, and this is the larger uptake area for the concentric needle electrode. A few words about the principle of jitter analysis. Here is a single fiber recording from a patient with myasthenia. We record from 2 muscle fibers and time lock the recording on one of the spikes, in this case the first one, and see a variability in the arrival time due to a variation in the synaptic delay in the 2 motor end plates involved. Here is a recording with normal jitter, and in the same muscle we have another position where we have motor end plates with a slightly increased jitter, and one area where we have even more increased jitter and individual impulse blockings. The jitter may be studied either with voluntary activation or, as in this case, electric stimulation. We stimulate with the needle or with the surface electrode and record the jitter between the stimulus and the recorded spike. If the jitter is less than 5 microseconds, we have stimulated a muscle fiber directly, and if the jitter is more than 5 microseconds, it is a nerve stimulation. The jitter parameter concerns time variation between 2 signals. Originally, this was obtained by measuring the time when the signal passed an amplitude level on the 2 signals. Here is the start of the measurement, and here is the end when the signal passes through the window. This technique is used in some equipment. Another method is to make peaks, mathematically peaks from the signals, and measure the variability between the peaks. Here's the triggering peak, and here's the peak on the second signal. The peak technique has an advantage in the situation where 2 action potentials are riding on each other. Here we will get an error in the measurement, but the peaks will give a more correct value. Here I will show 2 displays of jitter analysis. Here are the slow sweep speed, and this is with the amplitude level, where we see the signals here and the interval between them plotted on the y-axis, and here you have the jitter in these dots, and this is 100 discharges. This is the peak method, where we have the signals here, and the dots are now running here, and the jitter is displayed on the x-axis. We also superimpose 5 to 15 signals to check the quality of the recording. Now we will talk about the specifics of jitter analysis with concentric needle electrode. A display of some different recording electrodes to show their different recording surface, the monopolar, the concentric for multi-unit analysis, the facial small concentric needle electrode for jitter analysis, and the single fiber electrode. And you see the recording surfaces have this area 0.0 to 140 and so on, and they are very much smaller in the concentric small electrode and even much smaller in the single fiber electrode. Some practical hints is that we use the concentric facial needle, usually a slightly slanted direction of the electrode through the skin. We hold the electrode like a pen. There are no specific rules for rotation of the electrode as we have had for single fiber electrode, but we optimize the signal by small movements, usually out or in. And with voluntary activation, we ask the patient for the slightest possible contraction, and we do not start to collect data until we have good signals. We try to get 100 discharges for each recording and aim for 20 recordings for each muscle. When we have electrical stimulation, we use 5 to 10 Hertz. We stimulate the nerve and insert this concentric needle electrode into the twitching part of the muscle. We use a slight stimulus intensity to get very few spikes in the recording. We must make sure that the spike in focus is supraliminally stimulated, because with understimulation we will get jitter and blocking in the stimulation point. So if the recording shows abnormal jitter, we should always increase the stimulus just a little to see whether it disappears or not. We measure the jitter between the stimulus and the spike. The amplifier settings. Here is a summary. Concentric for multi-unit analysis, 5 Hz to 10 kHz. Single fiber to get rid of some slow components is 500 Hz to 10 kHz, and the recording with the concentric electrode 1 kHz to 10 kHz is found to be the optimal. And here are some examples of recordings with the concentric needle electrode. Here is a good recording where we particularly look at the rising phase of the signals. This is the triggering, superimposable, and here you see that there is a time variability, but no change in the signal shape at all in the rising phase, no notches or inflection points. This is another recording where the signals here are parallel, but they are riding on each other. This is acceptable for the peak triggering, but not for the amplitude level analysis. This is a signal where the first component obviously is a summation of 2 or more fibers. We trigger on the second component and can measure between second and third, but not to the first. And here we trigger on the second component, and obviously here we have some disturbances. These lines are not in parallel. Here's a recording with a single fiber electrode, and you see the sharp spikes with constant shape at consecutive discharges. And here's a recording with the concentric needle electrode. This sound is a little more dull, and these signals have a slightly lower slope, longer rise time, and this is the sound of it. And here's another recording with the concentric needle electrode when we are a little closer to the 2 muscle fibers, and we get a little more sharp signals. Here I will show you a few examples of recordings. In this case we trigger on the first and we see the jitter displayed on the second one with parallel rising lines. The jitter is 15 microseconds. Here's another where we trigger on the second one and we see the jitter here 21. And here is a multi-spike recording. We trigger on the first and can measure the jitter between 1 and 2, 1 and 3, 1 and 4 with the different jitter values here. Here's a situation where the first spike obviously is composed of at least 2 muscle fiber action potentials, and since this inflection point here is below 50% of the maximal amplitude, we can accept this recording since this fiber has probably very little influence on the peak. When we do the voluntary activation and trigger on one of the recordings, the jitter is always seen on one of the spikes, and that is the summation of the jitter from the first triggering and the second spike. And this is particularly obvious when we have multiple spike recordings and happen to have a large jitter in the first component, then all of the others seem to have a large jitter. So here I want to show the effect of triggering. We trigger here on the first and we measure the jitter on the other three spikes. And here is the individual jitter values. And we summate them to something called jitter sum or J sum. When we trigger on the second component, it is another J sum. And here in the third panel we have the optimal situation, so this obviously has the smallest jitter, and this should be the most correct value to report. Some instruments do this automatically and find the best trigger position. We also perform jitter analysis with concentric electrode after stimulation. Here we stimulate with a surface electrode. We can also use a monopolar for stimulation here. We start to stimulate and get the twitching part of the muscle and insert the needle into the twitching part. And then we obtain signals that may look like this. This is a very nice single fiber action potential with parallel rising phases. Here is a recording a little more complex, and obviously the first part here is a summation of at least 2 or more single fiber action potentials. So when we should measure the jitter, we do not use this one, but we can use the other 3 spikes. And we obtain the jitter between the stimulus and the individual peaks here. This is another situation, even more complex, and when we superimpose we see nice spikes here, but this one is obviously a composition of at least 2 muscle fibers. This one we do not accept, and here we have a disturbance in the peak. We do not accept this one. This is a recording that looks nice, but when we superimpose, surprise to surprise, we see that this must be a summation of a few fibers, and also here, also this component is a summation. So this recording cannot be used. Here's a recording from a patient with myasthenia with increased jitter, 64 on this one and 43 on this one. And here is another recording from a patient with myasthenia where there is a dropout of some components here during the recording. This can either be due to an insufficient stimulation strength, or it can be a neuromuscular problem. This must be tested by increasing the stimulus strength ever so little. If it is a stimulation problem, the signal will be recovered. If not, it is localized to the neuromuscular junction. Here's a superimposition of the same recording. This is a situation where this spike is not a clean single fiber recording, but you can see clearly that it must be a summation of 2 muscle fibers. And since this occurs above the 50% line of the spike, we do not accept this recording. We have influence, a summated influence here from the 2 fibers. It's not a clean recording. Here are some other recordings with after electrical stimulation, and here obviously you see an increased variability due to the diffractionation of the signal here. These are 2 fibers here. This is another recording with small jitter here in one component, And this one has a jitter within normal limits, but still it is not a single fiber recording, but this is a summation of at least two action potentials. Reference values for jitter obtained with concentric needle electrodes have been established in a multicenter study. Here are the mean value for a recording of 20 potential pairs, and here is the jitter, the upper normal limit for individual recording. And this is for voluntary and stimulated jitter, orbicularis oculi frontalis, and extensor digitorum communis. One can ask about the sensitivity when we compare the diagnostic use for single fiber EMG and for concentric EMG jitter. And multiple publications recently have shown that it's very similar sensitivity between the two methods. One thing that we always note is that increased jitter and abnormally decrementing response on repetitive nerve stimulation is not equal to the diagnosis of myasthenia gravis, but a sign of disturbed neuromuscular transmission, which, for example, happens in reinnervation. A few definitions of acceptable signals. This is more important than with the single fiber recording, which is simpler and easier to get clean signals. The signals with the concentric are monotonously rising positive negative signals without inflections, an important point, without inflections, notches or shoulders. And this is best seen as parallel rising segments when we superimpose 5 to 15 discharges. For quantitative analysis, the negative peaks should be separated by more than 150 microseconds, and even more if we have an amplitude level method for jitter measurement. During voluntary activation, we must make sure that we have a relatively regular firing rate from the patient. And with electric stimulation, we should make sure that we use a supraliminal stimulation intensity. The amplifier settings for CNE jitter analysis, 1 kHz to 10 kHz. And the sweep speed should allow the detailed analysis of the signal, which means that 0.5 or 1 millisecond per division is optimal. The gain is not crucial, but usually we make sure that the signal covers about 2 divisions on the display screen. And for quality control, during and after the recording, we superimpose 5 to 15 sweeps. When we assess the jitter quantitatively, we truncate high jitter values because we always have blocking of signals when the jitter is, for example, higher than 150 microseconds, and this gives a biological disturbance to the jitter measurement. So values above that are all called 150 microseconds in summary tables and mean values. We measure jitter in 2 ways, either as mean consecutive differences or mean sorted differences. Many equipment can do both these recordings, and we shall use the lower of them for each recording. If possible, we should find a trigger that gives the lowest total jitter in a multi-spike recording. In stimulation jitter, we do not use the signals during the first second after the start of stimulation. There are some biological disturbances there.
reporting from multiple spike recordings is a little more complex. If we have many spikes, we report all of them if they all are normal. If the jitter is abnormal in more than one spike in such a recording, we accept the normal recordings, but only one abnormal jitter value in each multi-spike complex, the one with the lowest jitter value. In stimulation studies, we report all jitter values from each of the spike as long as they are stimulated supramaximally.
At the end here, I like to make some additional comments on details for the CNE jitter recordings. I will give examples from the studies with voluntary activation and with electric stimulation. First, the voluntary activation. The first situation that may lead to misinterpretation of impulse blocking in voluntary activation studies is discussed here. The trigger level, which I indicate here with the arrow, is the amplitude threshold for starting the sweep. All signals with amplitude exceeding this level will be seen on the screen. In this example, we are triggering on these two signals, and it's only the smaller one, the one with lower amplitude, that has a double peak. The other one is a single one, and one can see the difference. This one is different from this one, and this one is different from the others. Here is another example, the same situation, trigger level here, and now it happens to be the white one, the higher amplitude signal, that is connected to another fiber. The yellow one is single. This may look like an impulse blocking. During activity, the muscle fiber conduction velocity is increased, and after a rest less than 1 second, the velocity goes down to a basal level. This is seen when we activate the muscle with bursts of stimuli and insert a pause here and a pause here. After the pause, the latency is longer. And if this pause comes in irregular intervals, it will add to the jitter. This irregularity is seen during voluntary activation, which adds a little to the jitter. And also if we have impulse blocking, that is disturbing both during voluntary activation and at electric stimulation. This is the most typical problem with electric stimulation. Here, two muscle fibers are activated initially, and they belong to the same motor unit. They occur all the time here. In order to make this stimulation supraliminal, the stimulus strength is increased a little, and now an additional spike is seen since a new axon is stimulated. And with another small increase in stimulus strength, a third axon is stimulated, giving its responses with a longer latency. This axon is stimulated subliminally because you see that the some of the impulses are missing. So we cannot measure the jitter on this one since it's not stimulated properly. And had we increased the stimulus to get this fully stimulated, then another fiber may have been seen, now in turn subliminally stimulated. This is a recording from a healthy muscle. It's not a myasthenia.
Sometimes with intramuscular stimulation, we see latency jumps in the response from this position to a shorter position. This is explained by so-called Axon reflex. This is a schematic explanation of Axon reflex. A weak stimulation, the recorded fiber is activated antidromically this way with a long latency, an axon reflex. With stronger stimulation, the electric field is increasing and we reach this part of the axon closer to the muscle fiber and therefore a shorter latency. The latency difference corresponds to the time on the axon reflex. Here's an example of a recording with latency jumps. Here's a given stimulation intensity. Here's high, and then we reduce the stimulus intensity. This line is drawn to the right, and we get a longer latency. And then again, we increase the stimulus intensity, and the latency is again shorter. When the reflex arc is long, the jumps are easily seen, but the reflex may be very short, and now the dual latencies are difficult to detect. And here is the distribution of latencies of the response. And when we superimpose, we may here and there see a clear dual distribution, but it's not so clear overall. And this could easily have been misjudged as an increased jitter. Then we have a few questions that are frequently asked. A short video like this does not cover all the aspects of CNE jitter, and some of the questions can be, can we measure fiber density with CNE? I said already from the beginning that is not possible, and because that has a completely different uptake area compared to the single fiber electrode for which the fiber density is defined. So here we rather rely on multi-unit potential parameters. Which muscle are optimal for the myasthenia diagnosis? Well, we should go for the symptomatic muscles. Often that is facial muscles, but if there are limb muscles, we should go for those. The typical is, however, that we record from orbicularis oculi and the frontalis muscles. And the rule is that if the first investigated muscle is normal, then we go to the other of the two. Internally, they have about the same diagnostic value. And if two muscles, particularly if they are symptomatic, have a normal jitter, then it's very unlikely that it's myasthenia, and to add a third muscle usually is not fruitful. Then it's better to ask the patient to come back after 3 months. Another important question is that about previous Botox injections. Remote effects of Botox can cause jitter in many muscles. And I should say that an unexpected finding of increased jitter should always lead to the question, did you have a Botox injection? The effect remains for a long time. It's unclear how long it is, but at least 3 or 6 months, even more in certain publications.
Thank you so much for this very good presentation, Professor Stålberg. I understand that you have a few more considerations to share with us before we head out to the questions and answers?
Yes, well, thank you very much. This presentation contained both basic things that are easy and to understand, and actually relatively easy to obtain also, particularly if we do slight voluntary contraction. That is the most common error that we make. We ask for too strong contraction from the patient, but let the patient just listen to the sound and just try to keep a low frequency of the motor unit discharges. And the discussion that I just had also contained a lot of very special things. And I took that in because I know that many of you now are able to record the routine single fiber EMG, so you are ready for more specific things such as VRF and Axon reflex. I was really eager to stress that the method is specific, which is opposite to what is said in literature. It is not specific for myasthenia, but it's specific for disturbed neuromuscular transmission. That is a difference. So remember, increased jitter is not myasthenia, it is disturbed neuromuscular transmission. Another thing that needs to be reiterated is that how many muscles do we need to be sure to rule in or rule out myasthenia? I should say if we go for symptomatic muscle and the jitter is normal, then it's not myasthenia. But if we go for muscles with very slight involvement, if the first muscle is normal, for example, orbicularis oculi, then we go to frontalis as a typical situation. And if that also is normal, it is unlikely that the patient has myasthenia and may be asked to come back after 3 months. If the first muscle already shows abnormality, we don't need to do a second muscle. And if the first two are normal, it does not add much at all to make a third muscle. And the daily problem is the question about the previous injection of botulinum toxin. We have, as you know, remote effects of botulinum, and therefore that can disturb very much the correct interpretation of single fiber EMG or jitter recordings. So be very careful. If you have unexpected increased jitter in the patient, ask the patient whether she or he had a Botox injection. The effect, unfortunately, remains for quite a long time. 3 months for sure, probably 6 months, or sometimes even more. Well, I think that is what I had to add, and I am ready for some questions now if you have.
Thank you, Professor Stålberg. We are now going to begin answering the questions submitted during today's presentation. And as a reminder, you can still submit questions through the question box in your attendee control panel. So we have a first question here that is, the presentation mentions the use of facial concentric needles for recording. And give me just a second so I can read it properly. Are there any reference to the use of monopolar needle electrodes to single fiber EMG despite the increase of recording area?
Well, the monopolar and the concentric in principle give the same jitter. There is no difference there. but it's more difficult to get clean signals with the monopolar since we have a larger uptake area and remote activity. And there is no it's not a good idea to just change the filters. For example, changing from 1 kilohertz that we use regularly for concentric to 2 kilohertz or 3 kilohertz. We get rid of some slow wave components, and the sharp spiky parts will remain in the signal but of lower amplitude, and the noise is not changed at all. So therefore we had a bad signal to noise ratio, and so that is not a good solution. Monopolar and concentric in principle the same, but a little more difficult with monopolar.
Thank you very much. We have another question. In stimulated single fiber EMG, what stimulus duration do you recommend?
We can do stimulation in two ways. One is by intramuscular small monopolar pins that we use for a cathode, as a cathode. And the duration is 0.05 milliseconds. If we use surface electrodes, we have found that 0.1 millisecond will do very well and is recommended.
Very good. I have another question. Practitioners are advised to record 100 discharges per recording. In cases where there is patient movement or artifact, can the recorders be further filtered? And what is the minimal acceptable amount of discharges per recording in such a case?
Well, first of all, there is no way that we can reduce the patient's movements electrically with filters or anything else. We must try to get a calm recording condition, most difficult naturally in babies and small children, but I think it's a must to have a calm background situation. We cannot filter away that. The other part of the question was how many discharges do we need? We aim for 100, but if we get at least 50, we are happy. If we only get 10 or 20, we don't think it is correct. So we go for minimum of 50, but aim for 100.
Very good, thank you. I'm going to hand it over to Sanjeev because I understand he also has some questions lining up.
Thank you, Philomena. Erik, it was a fantastic talk. Enjoyed it very much as usual. So let me start with the questions that are presented over here, and I will read it to you. When we use concentric needles, the individual spike can be summation of action potentials from more than one muscle fiber. So how can we require that these summated spikes should have the same rise time if each fiber has a different jitter and maybe even blocking or when there is an increased jitter?
Sanjeev, the essence of the question is that when we have summation, was the question whether we can accept it or not?
Correct. I mean, if there are pathologic, if there are two fibers producing a spike, obviously the rise time may not be parallel on every recording.
Correct.
Should we accept that or should we discard that?
Yeah. The reason why we discard the summated potential is that with summation, we can have either an abnormally low jitter. Think of a situation where we summate 5 or 10 or 100 fibers like an M response. There is no jitter there at all. And therefore, the summation of a few fibers can give the erroneously low jitter. But more commonly, they ride on each other up and down, and usually it gives an erroneously high jitter. We don't know exactly where we are, so we suggest to try to get really clean and nice signals. And by moving the electrode, one can always get one of the summating fibers to dominate the picture, so that the other one will be smaller and the fibers closer to the electrode tip will be larger.
Excellent. The next question is how to ensure a regular firing rate during voluntary jitter analysis. Do you have any tips?
And very good question, naturally, and it's important. And muscles are different. Some are more easy to activate regularly. Others are more difficult. One very important thing is to listen to the sound and learn the patient you see what happens when we increase the force and decrease the force, and how we can play around with firing rate. The patient learn that quite quickly, and when they listen to it, I think that is the best trick. I have no other very special situation. When we do the frontalis, I ask the patient to look up to the ceiling, and if we record from the orbicularis oculi, I ask them to close the eyes just a little, and usually we can get quite good and even frequencies.
Okay, thank you. There's a question. I was under impression that EDC was not a go-to muscle. Is that correct? You still don't do EDC, or you just stay with the facial muscles?
The beginning of the history of single fiber EMG in 60s and 70s, when we did the recording with the original single fiber electrode, we found that ED's extensor digitorum, as it is called nowadays, there is no C in the name, was very easy, because the topography of the motor units were such that it was relatively easy to obtain potential pairs, much easier than the biceps, for example, and not much affected by age. Now, when we see the principal use of the technique in the diagnosis of myasthenia, orbicularis oculi and or facial muscles are usually more involved than extensor digitorum, and therefore nowadays we use the frontalis, orbicularis oculi, and so on. When we do the concentric recordings in the extensor digitorum, is a little more difficult with the summation and so on. The thing that was advantageous in the single fiber recording is a disadvantage with the compact motor units for the concentric electrode.
Okay. Here's an interesting question. If jitter is normal, or the action potential appears stable initially during stimulation single fiber EMG, you see it is normal. Is there any merit in increasing stimulus strength?
The simple answer is no. We may get a jitter that is changing from upper normal limit, let's say 35 to 31, but no, we only increase the stimulus strength when the jitter is abnormal, and we must test whether it's a technical or biological.
Okay. Is it okay to look at the jitter along y-axis or x-axis? Does it matter?
No. I showed the two examples from two different equipment. The display is in one of them on the Y, and the one is on the X-axis. It's up to the user where he or she feels most comfortable.
Okay. I will read the question. If we do single fiber EMG, or let's say concentric needle EMG jitter recordings very early when the patient has ptosis, very early on, can we have false negative results for orbicularis oculi? And then should we wait for a few weeks to do the EMG again to avoid false negative?
I should say we should think of this as a very simple thing. The ptosis, if we are talking about ptosis due to myasthenia, the ptosis is due to loss of active muscle fibers, which is due to disturbed neuromuscular transmission. So ptosis with normal single fiber EMG is not myasthenia. Then we can talk about myopathy or other things. But as soon as we have a weakness in the muscle, whichever muscle it is, then the jitter is increased.
Okay, and that actually brings to the next question very nicely. What about jitter in myopathies? It's really difficult. So what instructions or recommendations do you have?
Yeah, problem. When I answered the previous question so categorically, yes. In myopathy, when we do the single fiber recording, we see a slight increase in fiber density. Surprise. And what is that due to? Well, we think that in myopathy, we do not only have fiber atrophy and so on, but we have necrosis, focal necrosis, regenerating muscle fibers, we have split muscle fibers and so on, and that give an abnormal jitter. Abnormal jitter due to secondary neurogenic changes or regenerating muscle fibers, and small jitter because of splitting. So now I should say that to a very small but significant extent, we see a slight increase in jitter also in myopathies. In neuropathies, we have much higher jitter, and also naturally in myasthenia.
Okay. The next question is, can jitter differentiate between ocular myasthenia and a generalized one?
The answer is no. The classification is a clinical one, and we have found, first to our surprise, and then it has been seen also by others, that in myasthenia we have in ocular myasthenia, where we clinically only have involvement of facial muscles, we see in 60% of the patients a slight increase in jitter in the extensor digitorum. And then you can say, shouldn't that be called generalized myasthenia? No, because the classification is on clinical grounds.
Okay. Okay, I did not follow this question, but it says often EDC is used there to compare with orbicularis oculi and frontalis. So I'm not clear about this question, but does that mean that can we use both muscles, like one EDC and one frontalis instead of two facial muscles?
And I think that usually the typical myasthenia is more affecting facial muscles more than the extensor digitorum. So if we just blindly make an answer to this question, is that we prefer two facial muscles rather than one facial and an extensor digitorum muscle.
Okay.
And it's a typical gradient and difference between this muscle. On the other hand, if you take other diseases, for example, myositis, then you have more abnormality in the flexor muscles of the forearm than in the facial muscles. So the pattern of muscle distribution is important for us in EMG, and in myasthenia, it is usually going for facial muscles.
And following that same line, the question is, what muscles do you recommend for musk myasthenia?
There we have a slightly different pattern, certainly also in the facial muscles, but for example, neck muscles are often involved, and we don't have a big material for neck muscles in myasthenia, but in MUSC, we often see abnormalities, and it's easy to make a recording. Patient is lying down on his belly and lift up the head a little, and we can get quite nice recordings from neck muscles.
What about patients who are on medication? Do you ask them to stop medication, or do you have a time limit, or what's your policy?
Depends on what medication. Steroids we do not bother about. The patient remains on that because they are more long-term action. If the patient is on mestinon, for example, then it has disappeared from the body quite a lot in 12 hours. So our routine is to take the patient in the morning for the test, and the patient has not taken his morning drugs. So usually they have been without drug for 12 hours, and that should be sufficient. Unless the patient has so severe symptoms that he can't do this, but we ask them to bring the tablets to the EMG lab to start medication right after the EMG recording.
Okay. You had indicated that you like to have 50 discharges to get the jitter value. But what if you can see the jitter, increased jitter and blocking within the first 20 discharges? Then can you still accept that recording?
Well, you can accept it for what should I say, a semi-quantitative assessment that it is really abnormal, and if you trust that you have abnormality because you have so nice signals, so I must say yes to that. But okay. On the other hand, you know, the normal firing rate is often about 10 or 15 hertz. And if you, now the question was 20 discharges, that is only 2-second recording. I think it would be better to go on a few seconds more, up to 10 seconds, then you have 100 discharges.
Okay. Do you have any suggestions for reference values in older people, more than 75 years?
We saw a slight trend in our multicenter study for some of the muscles, but and I think when we come to higher ages, we have both more fiber density, which is normal reinnervation, and due to that we have jitter, neurogenic jitter, and we have to look at the old cases, patients above 80, to see if there is a difference. At present, the reference values cover from young ages up to 80.
Okay. Well, I think I have got another 25 questions here, but we are running out of time. So my apologies if I don't select everybody's questions. So I will come to the last question, which I find it's most interesting. Which technique do you prefer, stimulation or volitional? Especially with concentric needle.
I say volitional without hesitation, and that is my personal preference. I know that many laboratories use electric stimulation with great success, and they are experts in that, and they like it because it's so easy, they say, to get spikes. It looks so easy when we do it. The artifacts are more common in electric stimulation. The subliminal stimulation, you know, if you stimulate a group of axons, 3-4 of them, and get many nice spikes, some of these axons are probably subliminally stimulated, so we always have that problem. So when we are going to interpret the stimulated jitter, we must look at each individual spike and make sure that that particular spike is supraliminally stimulated. that is not the problem in voluntary activation, but in voluntary instead we have the problem with the irregular firing rate. And certainly in some situations we must use the electric stimulation, which we do in unconscious patients and in small children.
Okay, and one last question. Do you check temperature before doing study?
No. On the patient? No.
Yes.
No, we don't. We don't. We think that the normal temperature is there, but it's a very good question, because when we do experiments on this and when we do particularly the rep stim, cooling of the neuromuscular junction will improve the transmission, and warming will make it more difficult. Patient can eat ice cream and like the Swedish cold old churches, and they do not like the sauna because they feel weaker. And that we should think of when we take care of patients in the intensive care unit, not to have overheated patients. The neuromuscular transmission is not happy with heat.
I think I will stop my questions over there. Over to you, Philomena.
Thank you very much, Sanjeev, for conducting this. And unfortunately, we couldn't get to all of these questions. And this concludes our seminar for today. I would like to thank you, Professor Stålberg, for your amazing and informative presentation, and also to our audience for your engagement and great questions, and also for you, Sanjeev, that you have been managing all of these questions as well. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you could complete that and provide your feedback. You will also receive a follow-up email with a link to view the recording of today's webinar. And we would always love to hear from you, so please contact us via email should you have any questions regarding today's webinar. If you like to access future events and educational programs on the Neuro Training Academy, we invite you to join. You can visit neuro.natus.com/academy for more educational events. And on behalf of Natus and our Neuro Training Academy, thank you again for joining us today. Have a great day, evening, and we look forward to seeing you next time.
Thank you.
Thank you very much, and good luck with these Jitter recordings to all the participants.